Thank you everyone for joining us today in this fireside chat with Dr. Pierre Theodore without any fire. So we are virtual, but thank you so much. And Dr. Pierre here is in California, joining us from a completely different time zone. So Dr. Pierre, thank you so much. And if it's okay with you, I will take this opportunity to introduce you and share your bio with all our attendees.
Sure. Of course, Rafi, you're too kind.
Thank you. All right, thank you everyone for joining us. Pierre Theodore serves as a Vice President of Global Public Health at Johnson & Johnson and is a thoracic surgeon on the adjunct faculty, and the adjunct faculty of Stanford University. In his role as the Global Public Health Equity Program Leader, he is responsible for the acceleration of novel technologies and strategies that overcome access and availability barriers to healthcare. Board certified in general surgery and thoracic surgery, Pierre has over 2 decades of experience in cardiothoracic surgery, surgical education, entrepreneurship, healthcare venture investing, and innovation. After obtaining an undergraduate degree in philosophy from Princeton University, Pierre received his Doctor of Medicine from the University of Virginia. He completed general surgical and cardiothoracic surgery training at Johns Hopkins Hospital and University Hospital Pitié in Paris. Pierre completed a postdoctoral fellowship at the Massachusetts General Hospital Transplant Biology Research Center at Harvard Medical School. Pierre is a commissioned officer in the United States Navy Reserve Medical Officer Corps, holding the rank of commander. Pierre is an avid cyclist and father of 2 residing in, and he's residing in San Francisco, California. So with that, I welcome Dr. Pierre. Thank you so much for being with us today.
Hey, Rocky, it is such a delight to be with you and having had the chance to get to know you over the course of the last couple of months, really to recognize you and your team, all you've done to really bring this event together. It's just a remarkable testament to a vision that you and your fellow supply chain leaders have really had around some issues related to diversity and equity and inclusion. And I'm just delighted to be here with you. And I did want to say I have one thing to push back on. I actually brought my own little fire here. So I just want you to know that I have one with us. So in case you need to bring it out for the fireside chat, it's there. So it really,
thank you. That is so amazing. Thank you. Now I feel warm and cozy and we can have a great conversation.
Absolutely, absolutely.
Wonderful. So our first question, and I think this is on mind of everyone. It is on mine, and I have to ask this. Tell us about your title. Like, what does VP of Global Public Health Disparities Leader mean?
Yeah, thanks for that question. And I think it's an important one for us to be able to dig into what our responsibilities are and for me to express what a new, in fact, title is in global public health and what the intention is for that role. And, maybe just to step back for a moment, one of my mentors in medical devices, really once said to me, this is the kind of company through its creativity that sometimes will allow you to really create your own role, and that'll allow you to look at significant problems. And if they are problems that are also appreciated by the enterprise, will allow you to create a program related to that. And I think it's a real testament in a way to J&J and its creativity that it's exhibited over the 130 plus years of its existence. And so I, by way of background, as you mentioned, I'm a clinician. And I came into J&J through R&D roles, both in medical devices and at the enterprise level, largely focusing on oncology. But I have a very a definite passion for global public health initiatives. I'm of Haitian descent. I spend time, I was on a call with Haitian healthcare colleagues earlier today to make plans for some mission work to be done near Port-au-Prince in the end of the next month. And it's a very important thing to me to be engaged in global public health initiatives. So when the opportunity arose to really join that part of the company that's largely focused on marginalized populations, largely focused on Sub-Saharan Africa and Southeast Asia and Central Asia as well, I really did jump at that opportunity. And in coming into global public health in a medical affairs role, really stepping back, it was a realization that I've gained over many years, both in the clinic and in quote business unquote, which is really what are these significant barriers that are structurally faced by our patients that interfere with their access to our medical devices and our pharma solutions. So in a sense, we can have the world's greatest pharmaceutical and medical device technologies and innovation, but if there are structural impediments that really disallow the patient from having access to them, then that limits the overall impact that we can have. And global public health sits in a very unique and I think powerful position in the enterprise, in as much as we define our success in terms of how much impact that we have on populations and how much impact do we have on the patients. And really sort of looking at that question of how do we maximize our impact, my fundamental belief was creating a program and a small team dedicated to understanding what are some of the structural divides that happen by population, by race and ethnicity and by gender and by location and by presence in a rural setting versus an urban setting, by poverty, if you will, really dissecting those concepts within poverty to come up with solutions to maximize the impact of our world-class portfolio. That's really the nature of healthcare disparities work. So my responsibility is now across the portfolio inside of GPH, focusing on diseases such as HIV and tuberculosis and surgical disease and soil-transmitted helminthic disease, for example, among others, is to really focus on what are those structural impairments that the patients will face that prevent them from having access to our portfolio. And that really, in a nutshell, is what a health disparities leader is measured by and asked to do, which is to come up for those sort of solves for those structural barriers that exist and are often prohibitive in low and middle income countries.
Okay, wow, that is amazing. Oh, I had no idea. I had to ask, and I'm sure that's a question that everyone wanted to know. So thank you so much for explaining that to us. What does that really mean? So why is health equity so important? I think you started to mention a little bit right now, but what does that race to health equity, the word itself, mean, and why should it be important to all of us?
Yeah, so it's an important question because the term equity is often thrown around all over the place without really grounding ourselves on what the term is really meant to describe. And moreover, often equity gets lumped into diversity and inclusion, and it's sort of a co-associated, but really quite distinct in many ways from diversity or inclusion. And it's important, I think, and I appreciate you calling that out, for us to really ground ourselves on some sense of a common understanding of what that term itself means. And in many ways, equity it's both a goal and it is also a process to overcome poor healthcare outcomes that are a result of individual patients' membership in a population. So if you think about it, although we are, of course, individuals, by virtue of our where we live and our national identity and our ethnic status and our socioeconomic position and many other descriptors, many of those will ultimately define our healthcare outcomes. So as you understand one population versus another, whether it's urban African Americans in the United States, whether it is rural women in Kenya, for example, you start to see trends and you start to see persistent, repeating poor outcomes often in certain populations versus another. And what's important is that it's not just a question of the outcomes differences. Outcome differences exist for all sorts of reasons, from the biologic to just luck. But it's when those differences in population outcome are related to some sort of a historical legacy of disadvantage. So that the reason why an individual as member of a population does poorly or has a poor outcome is related to this sort of, as I said before, a historical legacy of disadvantage. That's the driver. It is an injustice. So an inequity is effectively a combination of a healthcare outcome difference with a sort of a social injustice. When they come together, that can rightly be called either healthcare disparity or health inequities. And health equity work, in my mind, is both the the goal of eliminating those differences in healthcare outcomes that happen in one group versus another. But it's also a process, which I hope we'll get into a little bit in this discussion, which is, well, that's all great, but really, how do you do it? What are the tools and the levers that exist to offset those differences in population health outcomes, again, that are appended to some form of disadvantage or injustice?
Wow. No, thank you. Thank you so much for that enlightenment, right? Because like you mentioned, equity itself just gets so tangled in and mixed in with diversity and inclusion that it's really important for us to understand why it's distinctive and what makes it different, right? So yeah, thank you for sharing that.
That's an important point. I think it's worth digging into that for just one quick second before we maybe go on to the next topic, which is, how do diversity and equity and inclusion interrelate? They often trip off the tongue as one thing, but they in some ways are quite distinct. And in my mind, I think of it in very gross terms as diversity is to a degree, what do we look like and what do we think like? It's a diversity across both the people that are represented in an organization, but also the thoughts and background and belief that can drive greater levels of creativity. And this is the subject of many studies that suggest that greater diversity can lead to just that, a more creative, more innovative organizations, which only makes sense because we're hearing more of a spectrum of ideas and a spectrum of voices. And so in some ways, that is the power of diversity to make an institution stronger and better. But equity in some ways is actually a little bit distinct, at least around health equity, because it's not so much what do we look and what do we think alike, but it's also what do we do in the external environment? What is the impact of our portfolio, of our services, of our employees on those patients, individuals, and mothers and fathers that at J&J we serve? Therein lies this challenge of health equity, which is where we look external to the organization and say, how can we be essentially a tool for greater health justice for those populations and patients that we serve? And that's a little bit of the distinction in my mind between diversity, inclusion, and equity. So instead of seeing them as sort of, maybe three elements all linked together, I think of them more like a pyramid where diversity is the foundation, diversity of thought and belief and background. And that diverse population needs to be included in decisions and strategy and where the organization may go. And then the ultimate expression of that is how we ultimately drive a more equitable and a more just healthcare world around us through our capabilities. So that's in a sense how equity distinguishes itself from diversity.
No, very, very interesting. Thank you. Very insightful. So I'll take us to the next question is, how can a corporation, from your perspective, achieve health equity framework, and what are some of the key initiatives that they can drive to achieve that?
Yeah, so I think it's the question in a sense is not only how can a corporation, but I think a better way of looking at it is how does this corporation actually address issues of health inequities? Because, in large part driven by our senior leadership over the last several years, but really in the very fiber of what we are, that's really codified in our credo, is that this drive towards greater health justice is really, very core to the J&J mission. So in some ways, we're driving health equity by making sure that our life-sustaining medications, medical device, and consumer products, and life-improving consumer products really are able to be accessed by the largest number of patients possible. So in some ways, it's already fundamentally part, if you will, of our DNA. But more specifically, to really have a focused program in health equity requires what I sometimes call upstream thinking. And in fact, even in healthcare, there's now a concept of upstream medicine, which is to say that we're all aware of the phenomena of gun violence or of trauma or of HIV infection or of lung cancer or colorectal cancer, but we can always ask ourselves, well, what comes upstream of that in terms of the primary prevention capabilities? Is there a healthcare system that was in place to pick up these processes earlier and treat them adequately? But then you can even go upstream of that and ask, what are the determinants that individual patients face that ultimately determine the severity of the disease and the long-term outcome? And so if you consider it as sort of a stream where the actual manifestation of the disease that we treat with a device or a drug is the sort of the end state, it's moving upwards, upstream, past prevention, for example, to really start to address some of those social determinants that are ultimately driving healthcare outcomes. And while that is a challenge, there's also significant bang for the buck, if you will, by really having to focus on some of these determinants that often are, very critical to what the disease looks like in a given population, and frankly, even in a single individual. So, coming from our most senior leadership and our executive committee on down has been really a mandate for us to look carefully at what these determinants are and what can we do by pulling out innovative activities and innovative efforts from the community around us. So that's everything from setting up health equity innovation challenges, both in the sector and at the enterprise level. It is also a direct encouragement across the entirety of J&J through the Our Race to Health Equity program to really think creatively about what we can do to address some of these upstream community-based organizations that ultimately will, with the success that will come, that ultimately will offset some of this historical legacy of differences in healthcare outcomes that we see by population in the United States, and frankly, I think that we see worldwide. So a corporation can start off with a mindset of understanding that disease is, it's on a continuum from those upstream determinants to prevention, to the healthcare system and its capability to deal with the disease, to the manifestation of the disease under treatment. And then to encourage, as I said at the beginning, this upstream thinking. And that's what I think J&J has largely done through what we are calling our Race for Health Equity, that really has essentially three components: where we work internally to drive greater diversity in our own ranks, where we develop ongoing affiliations with community-based organizations that can help us to realize efforts, and we continue to seek innovation specifically focused on health inequity. So by taking that sort of approach, we are able to really bring in strategies to address health inequity. So I would say those are a couple examples of how our corporation, and frankly, many corporations, can address issues related to health inequalities and health inequities through the levers that only a corporation as large as ours and a few others can actually pull.
No, that is great. So just on the same line of thought, right? So corporations like us, when we are doing so much, and you said it's all about the mindset and also the innovation and the strategies around it to make healthcare so accessible, what are the barriers and the challenges that you have seen in your role trying to accomplish this task, right? And is there something you want to share? Anything that stands out in terms of a big challenge or a downside to it? A different perspective that you want to add?
It's an important question, right? I'm always wary of anyone that sort of speaks to the upsides only and isn't willing to dig in and give bad news and really lay bare what are some of the challenges that are faced. And I think that's an important part of this discussion. If it was easy, we wouldn't need to have a Race for Health Equity. It would already be integrated into everything that we do, both inside and outside of J&J. So there clearly are some significant barriers, and I appreciate that question because it allows us to speak to some of them. And I think one of the first barriers from our standpoint inside of J&J is as we consider what does it mean to do work a little bit further upstream, really there's an opportunity cost. We have a primary focus on our pharmaceutical and our device and our consumer sector. And so as we start to look at these other elements, of course, there is always a worry that less of our emphasis will be on the real core elements of what we do at J&J. And so really being able to look carefully and critically at these upstream issues so that we can pick and choose those that have the maximum benefit to our patients and to our business, frankly, because fundamentally, I think that addressing these barriers, these systemic barriers, is also good business practice for us. But there is a real challenge. So it does require a slight adjusting of our focus, if you will, and that represents a significant barrier, as it is any time when you begin to develop new capabilities and new approaches to any disease process. And I think this fits into that same issue in terms of a challenge or a barrier. As for the question, are there really downsides? Well, I don't think there are specific downsides per se of trying to address health inequity. However, health inequities are challenging. Sometimes they involve things like transportation and legacies of racism or discrimination. Sometimes they involve clean air issues and housing and incarceration and things of these sort. And the fact is, it's not as a downside, but they may be well outside of the purview of any given organization. So that downside doesn't mean that is a critical problem. It means that to have ultimate success in this kind of work requires collaboration, because it's quite clear that if you're going to go upstream, you really do need different organizations, from public-private partnerships, private sector, civil society, holding hands in some way to address some of these significant issues of access barriers.
Yeah, wow. No, this is amazing. Thank you so much for all these insights. I just want to know if there is any final thoughts or any key points that you want to leave the audience with. Like, what do you want us to take away from this conversation, and what should we focus on from your perspective?
Yeah, that's such a key question and great way for us to finish up. And it's interesting. On the one hand, we could say, okay, there are new roles, or there are new positions, or there are new programs like Our Race for Health Equity. And then the question is, how will that play out through the organization? What will that organization do? What will the structure be, and so forth? I think that those are important concepts. However, what I would want to leave our audience with is that issues related to healthcare justice and health equity should be on all of our minds. I mean, in fact, it's one of the drivers to an innovative company. And I think sort of asking that question, someone said in GPH that, at the end of every meeting, we should just ask ourselves, who is being left behind? And in a sense, having that mindset of who or what population is not being addressed by a technology can actually open up new potential opportunities for us. And so it's sort of broadening our thinking in a sense as to who our customers are. And frankly, what we're finding is that many of our large customers share with us an interest in addressing population health issues. The truth is that population health issues are expensive. They are expensive both in terms of most importantly, in terms of the cost to the patient borne by the patients themselves, who have inferior outcomes and foreshortened lifespans and the like. So that's the first cost in a sense. But they are also expensive to both society at large and also to many of our large customers as well. So understanding that health equity is an additional benefit that we bring to the markets that we serve, in my mind, it sort of opens up a little bit of the conversation. What about this device? What about this service? What about this customer? What about this supplier can have an ultimate impact on outcomes differences by population? So what I would hope is that over time, we build this in to kind of our mindset. If you're an innovator, or if you're in R&D, there's a sort of idea of always asking 5 whys in a row. So, why did the cancer happen? What was the mutation? What was the pathway? What drove the pathway? What was the factor in the environment that might have led to that? So you kind of continue to force yourself to think about what are the precedent causes of the disease. And I would say we should do something along that same lines in terms of health inequities. When we see a population health difference, why do we see one population with, let's say, 2 times the mortality rate in advanced prostate adenocarcinoma in one population for another and ask, what are the drivers? And when we do that, we will find, whether it's at the level of the genome or whether it's at the level of how we interact with each other in society, we will find new solutions. So I would leave our audience with this idea of having that mindset of health justice, because A, it's the right thing, but also it will open up new opportunities for us in terms of the business that we do day in and day out at J&J.
Wow, thank you. That is awesome. Thank you for sharing that. Those are great pieces of advice. We do have a question in the chat Q&A that just came to me. If you don't mind, can I share that with you?
Of course, I'll do my best.
Okay, so when Dr. Pierre mentioned preventive healthcare, how can organizations can actively contribute to reduce some of the root causes that generate to lifestyle-related diseases like diabetes, high blood pressure in low-income communities, many turned into food desert areas, etc.?
Yeah, I mean, I think the question in some ways has the answer kind of included in it. And so let's take because I think there are a couple issues here of hypertension and food deserts, and let's look at something like morbid obesity. We know, for example, that morbid obesity has many factors to it: exercise related, exercise endocrine related, health deserts, lack of primary care, for example, and all those things conspire, and what you might call dysnutrition. It's not so much that there's not enough food, but the food that's provided is not of high quality, and the subsequent result is obesity. So when a company that has a medical device business that is critical to addressing, say, obesity surgery, can actually expand a little bit of its aperture, as we are doing, and to think about what are some of those determinants, exercise related, insurance coverage for patients with obesity to drive weight loss, for example. So I think it's really, the question is an important one. It actually has some of the answers inside of it. You can start with the disease process, but again, as I mentioned earlier, give a couple whys in a row. Why is the population more obese? What are the drivers to that? And then what you find often is community-based organizations that are tied into those determinants. And those are elements that we as individuals can engage with, of course, but also so too can organizations and enterprises like J&J often engage with some of those drivers of the downstream disease.
Yeah, no, absolutely. I mean, you very well said that, right? I mean, who is getting left behind? There should be no one. Good health is a right of every individual, right? So whatever organizations can do, it's a step in the right direction. So thank you for all the work that you do at J&J, and thank you to everyone who works on such major initiatives to actually bring good health to everyone and make sure that it's accessible and affordable and available, right? So it's very important. And thank you for all the work that you do. And thank you for joining us today for sharing all these great insights with us, the downside, the barriers, and how we can actually make a difference together, right? So really appreciate your time here.
Absolutely, Rocky. It's my pleasure. Absolutely. So impressed and have so much admiration for all the work that you've done for the Discover program. And it really was a pleasure for me to join you today. So thank you once again.
Yeah, no, thank you. It's our pleasure. And I'm absolutely sure that I'll get great feedback from the attendees. And, they've learned so much with our discussion with you today. So with that, again, a big thank you, Dr. Pierre. And now back to the audience here. We will be going and joining the closing thoughts by Anu Hans. So please, in a few minutes, let's just go and connect and listen Anu so she can close the day. And then after that, we will have fun and the happy hour. And 75 of the audience members have received a special invitation to join us for the virtual game room. So please check your emails, and if you have received them, please join us after the closing thoughts, and we will close the event in a fun virtual gaming environment. So let's go and hear Anu Hans. Thank you.